You'll be able to view this one as well as past webinars and our new newsletters there in the chat. We also ask that you hold all your questions until the end of the presentation. We will have a dedicated Q&A session. Now, I know sometimes when you have a question and it's burning in your soul, you can definitely type it into the chat. And we can also, say that question at the end as well. So you do have those two options for the Q&A session. So now it is my pleasure to introduce our speaker, Dr. Christine Grant. Dr. Grant completed her training in medical genetics and medical biochemical genetics at the National Institute of Health National Human Genome Research Institute in Bethesda, Maryland. She joined Children's National Hospital in 2018, and her clinical and research interests focus on large molecule storage disorders, particularly lysosomal storage diseases. Dr. Grant has been closely involved in newborn screening for lysosomal disorders in our region since the first conditions were added to the screening panels in 2018. She has also participated in national advisory boards for newborn screening in Pompe disease. So please welcome and join me in welcoming Dr. Christine Grant. Thank you.
Hello. All right. Thank you all so much for having me. And I'm excited to tell you all about one of the loves of my life, newborn screening for lysosomal disorders. I'm so excited that they're on the newborn screen and helping save babies' lives. I am going to be sharing my whole screen, so I won't be able to see any chats that come up. So if there is something that comes up and you have a question, I can be interrupted, or hopefully we can answer everything at the end of the of my chat. And so I will be sharing my whole screen. So if you give me just a minute and then we can verify that everything is working. Can people see?
Yes.
Wonderful. Excellent. So I'm Christina Grant. I'm an attending physician at Children's National, and I direct the Lysosomal Storage Disorders program. And we do cover a lot of Southern Maryland, but we are licensed to see anyone in Maryland, and also a couple of the border states as well. So my disclosures, I will talk to anyone who will make drugs to help save babies and patients with lysosomal disorders. So I am an advisor or a speaker for Sanofi, Denali, and Regenxenix Bio, and we do some clinical trials that the drug companies pay my hospital for Sanofi, Ultragenyx, and Takeda. I won't be talking about any unapproved or investigational use of any specific drugs, but I will mention some clinical trials going on for some conditions without discussing any specifics. Goals and objectives for today, we're going to review the newborn screen process for lysosomal disorders in Maryland. I'll talk a little bit about the lysosomal disorders, the red flags for referral and what requires emergent treatment, and on the flip side, what can wait. We'll provide some guidance for babies who have positive screens. We're going to define pseudodeficiency because that's a hard concept to get even for some of my geneticists. And then the big thing is to discuss how genetics and primary care providers can work together to help keep families and babies safe. And then I also want to share resources for both providers and families while we're waiting for results or just in general. So first, to define a few terms, the newborn metabolic screen or newborn screening is the dried blood spot, screen of an enzyme or marker indicating a possible diagnosis of a disorder. It is a screen, it's not diagnostic. I will say that over time we are getting better with our screening, but if you see me say NMS or NBS, that's what we're talking about. Second tier testing is a second test of a positive initial screen that helps improve the predictive value. So the first test is positive, we do the second test because of the false positive rates, to improve whether it's a true positive or a false positive, and it helps reduce the false positive rates. So we'll talk about those. LSD, I'm going to use a lot. That stands for lysosomal storage disease. That does not stand for the other things that you might think of when you think of LSD, especially if you're an emergency physician. Pseudodeficiency is a genetic change that makes the enzyme appear low on a lab test, but does not cause disease in humans. So it can cause you to flag positive for a screen, but baby is just fine and will be fine their whole life. And then ERT, or enzyme replacement therapy, is a way to replace the missing enzyme. It's IV only, and currently there are no FDA-approved ERTs that cross the blood-brain barrier. So when we're talking about ERT, we are talking about systemic therapy that can only go where the blood goes and can't cross the blood-brain barrier. So soft tissues get treated very well. Bones are very hard to treat. The nervous system is protected, and so the ERT that we currently have approved by the FDA does not help nervous system symptoms of any of the diseases that we're going to talk about. So LSDs on the newborn screen in Maryland started in 2019 with Pompe disease, MPS 1 or Hurler syndrome, and Fabry disease. Last year, we added MPS 2 or Hunter syndrome, and just in July, Krabbe disease was added, so that's a fairly new disorder. For MPS 1 and Pompe disease, the damage is irreversible once the child is symptomatic, so they are time sensitive. Pompe is time sensitive on a days to weeks. MPS 1 is time sensitive on a weeks to month. So what is the process in Maryland? In Maryland, as you know, every baby gets 2 screens. Their first screen is usually at the birth hospital between 24 and 48 hours of life. And then the second screen is designed to happen around 2 weeks at the 2-week PCP appointment. LSD enzymes are tested on those screens, and if they're lower than the cutoff for MPS 1 and 2, there is second tier testing. So if the enzyme is low, the blood spot then gets sent for a second test that will help determine, is this more likely to be a true positive? Or if the second tier testing is negative, we can say that that low enzyme test was a false positive, and that won't be reported out to pediatricians, won't be referred. Pompe disease, any low enzyme will be referred to a genetic center. For Fabry, because that one is a test that will not have symptoms for years, and we have a lot of time before we need to treat. Any positive screen will have a repeat enzyme, and if there's 2 low enzymes, there's a referral to a genetic center. And for Krabbe disease, there is second tier testing prior to any referrals. So after the newborn screen, if you get one of those phone calls, hey, your baby has a positive newborn screen, you tell the state which of the referral centers you would like to refer the baby to, and then the referral center performs confirmatory testing. Sometimes that's repeat enzyme, sometimes that's genetics. A lot of times it also includes blood and possibly urine testing, looking for other signs of the disorder to help us determine, is this a true screen? Is this possibly one of those pseudo deficiencies? How severe are we talking about, and how quickly do we have to act for these babies? And then if the diagnosis is confirmed, the referral center starts treatment or monitoring depending on which is indicated for the baby. So possible results that you can get on a newborn screen is you can get a positive result, and that can be a couple of things. That's when the enzyme is critical or lower than expected, and for some of those syndromes that they also have a positive for second tier test. So it could be a true positive. The baby could actually have the condition. We can also see positive results in pseudodeficiency. So again, that's when there's a genetic variation that makes the enzyme not work very well in a dish, whether it's from synthetic substrate or lab conditions, but it works well enough in the body to prevent having disease in the human. And it's common in certain populations for certain disorders, so we can consider that a false positive depending on how you look at it. It's a positive screen, but the baby doesn't have the disorder. Carriers will also sometimes have positive screens. We see that more in some disorders than others, but if you only have 50% of the working enzyme, you might have low enough enzyme on the test, and we can't take the chance with these babies, and so they are referred to double check rather than missing a true positive. Or we can have a false positive from any number of reasons. A lot of these enzymes are heat sensitive, and so in the summertime, sometimes an enzyme might flag low because it was exposed to heat, but repeat diagnostic enzyme testing is normal. And in that case, the baby might not even need genetic testing. We can say, oh, that was a false positive. Maybe it was heat. Maybe it was something else with the card. But then the baby can be discharged. We can also get inconclusive or unsatisfactory results, and that means that the controls weren't passed. It doesn't mean that it was a positive result. Sometimes all of the levels are low. Again, it can be from heat exposure. It can be from there was too much blood put on the card. It could be from there was not enough blood put on the card. It could be the card took too long to get to the state. And so usually in those cases, it does require a repeat specimen to make sure that the screen gets completed. Lysosomal disorders are a little bit different than a lot of the other things that we think about for newborn screen. Usually people see a positive newborn screen and panic and think, uh-oh, baby's going to be very sick. I need to get them to the hospital immediately. They need to go to the emergency room because they can sustain brain damage if not treated quickly. Lysosomal disorders are not quite like that. They tend to be progressive, but they're not associated with those acute metabolic derangements or the metabolic crisis that we worry about in some of those other screens, like the organic acid screens or an MSUD screen that we worry about. Confirmatory and common lab tests are often normal, so I can't send the baby to LabCorp request and just check a CBC or check a lab that's done in most of these places because they really are only done in a very small handfuls of specialized labs throughout the country. Um, Usually most places don't have contracts, don't have the ability to send samples to these labs, and so they do need to go to a specialized hospital to be able to get the labs that we need done. For some disorders, there are screening tests. So there are sometimes urine tests, or I can test for markers in the blood, things that go up when the enzymes are gone. But for others, we do need to order the specific enzyme or to do molecular analysis or genetic testing. So now I'm going to talk a little bit about some of the diseases that we do screen for, what to look for, what things might look like when the baby does come to the hospital, and what treatment might look like, just so that you can recognize what some red flags might be or be able to reassure the family a little bit in some of these cases before they go Googling and find the worst possible outcomes that are on the internet. So Pompe disease, the gene is GAA, so you might see a low GAA level reported on the screen. Babies with a low GAA will be referred on any low enzyme level, and in Maryland, we don't have second tier testing, and so every baby will be referred out to genetics. People with Pompe disease have primarily muscle affected, so skeletal, but also cardiac. So cardiac is the scary thing in Pompe disease, where extra bits of sugar get stored in muscle tissue. There's a wide spectrum of disease in Pompe disease. The one that's meant to be caught on newborn screen is infantile onset. So these babies have hypotonia and weakness. They have cardiomyopathy that usually starts in fetal life, but you can see within a couple of weeks of life. They might have poor feeding. They might have macroglossia. They might not appear sick. It can be very subtle, or you can look at the baby and say, something's just not right. I can't put my finger on it. Baby might be just a little bit floppy, maybe a little bit of sweating with feeds, but otherwise they appear normal. And again, they don't get acutely sick. However, we're also catching late onset disease. So late onset Pompe disease is onset anytime after fetal life. Anywhere from later infancy to late adulthood, some people are being diagnosed in their 60s. And that shows up as proximal muscle weakness, and they usually don't have cardiac involvement. And so that is primarily respiratory and skeletal muscles. There is a high pseudodeficiency rate for Pompe disease, primarily in Asian populations. There's a particular genetic change that we see more commonly in people of Asian descent than other ethnic backgrounds. And so there might be a higher false positive rate in people of Asian descent compared to other populations. So infantile onset Pompe disease is the true urgent lysosomal newborn screen condition. Um, those babies we see within 48 hours with urgent labs and echo and initiation of therapy if needed. So let's talk a little bit more about those forms of Pompe disease and what I do if I get a positive screen. So initially we evaluate. So the biggest thing is going to be to talk to the referral center. Again, the state will call you and say, hey, we have a baby with Pompe disease. Which referral center would you like me to send them to? And they'll probably give you a little bit of guidance and remind you that this is one that you should talk to us quickly. But if baby is well, it's not something that we necessarily need to send to the emergency room for. Red flags that I would want to see the baby the next day or the day after would be hypotonia, macroglossia, a tongue that is just stuck out of the mouth like that. Every one of my infantile kids has had a big tongue, and the pediatricians have noticed it even before the newborn screen has called. Poor weight gain if they're just not able to gain weight, or any cardiac concerns in utero. A lot of times we do see either a little bit, in the most severe cases, we see a little bit of cardiac effusion that might go away, or maybe the heart looked a little bit thick. So if anyone has been concerned while baby was in utero, I would want to see that baby sooner. If there are no red flags, because we are referring after one screen, um, and because we don't have second tier, we do molecular testing by cheek swab. So that means that our center will talk to the parents, we'll have a cheek swab sent to the home, and do genetic testing. That takes about 3 weeks to come back. And so if baby does have red flags, I want to be seeing them sooner. But if there are no red flags, if baby is doing great, strong, gaining weight, we don't necessarily want to drag every baby into the hospital and out of their home and expose them to germs. Um, if there are red flags, we do set up an urgent visit at Children's. It's usually within 24 to 48 hours. I have a dedicated cardiologist who will drop everything and do an echo on a kid that I'm concerned about. We do have a cardiac evaluation with echo and EKG. We check their labs. Every baby who I've had with true infantile onset Pompe disease has had elevated CK and elevated transaminases, so ALT elevated because they're coming from muscle, not from the liver. We also check a urine biomarker, but it's not terribly sensitive. And then we do genetic testing on all of these babies for a couple of reasons. One, do they actually have Pompe disease, or are they just a baby who's a little bit hypotonic and might be a carrier? The other part is that genetic testing might help predict severity and guide therapy. If they have two completely broken copies of the gene, they're not making any enzyme whatsoever, they're more likely to be in infantile form, because I can't always tell the difference between infantile and late onset when I first meet a baby. It might also help guide therapy. Babies who make absolutely no enzyme are more likely to reject the therapy and need some immunomodulation. And it's kind of a big deal to turn off a baby's immune system if you don't have to. After these red flag babies are seen, if there's any cardiomegaly, we are starting the process of getting therapy started, even without having the genetic testing back yet. If the baby fits the criteria for Pompe disease and fits the criteria for infantile onset Pompe disease, we are starting the process to get treatment started. So again, the classic infantile onset form presents within the first few months of life, but really in utero, if you look back and look at their hearts. Median age of symptom onset is between 1.6 and 4 months. That's when you really see the weakness, but there are subtle signs within the first few weeks. In infants who go without treatment, death occurs within the first year of life from cardiopulmonary insufficiency. Their heart gets too big, they can't use their respiratory muscles to breathe, and they die from either heart failure or respiratory insufficiency. They get severe hypotonia, hypertrophic cardiomyopathy. Again, that respiratory distress, feeding difficulties, and macroglossia are our red flags. And the heart being so big also impacts lung volumes. So there is a typical EKG finding, which is cardiomegaly and a shortened PR interval, that our cardiologists will look at along with the echo to determine whether or not this baby is very high risk, or if baby can wait a little bit for the genetic testing to come back. There's also a non-classical variant infantile onset form, which we have seen on at least one Maryland newborn screen baby. So they are babies who present within the first year of life with motor delays, but they don't have the cardiac findings. And so they usually, if untreated, they will die from respiratory failure. And so it's also important to find them. The late onset form, again, is more hard to define. Late is any time that you're not a fetus and you don't have cardiac involvement. So late onset can present in the infantile period, or it can never present at all. You can go your whole life before you develop enough enzyme deficiency to ever show symptoms. It does have proximal muscle weakness and respiratory insufficiency, and in people who do develop symptoms, they progress to wheelchair use and assisted ventilation without treatment. There's usually not any cardiac involvement. And based on our newborn screen findings, unaffected mild adults are far more common than the ones that we know of. We're also finding adults on carrier screening, so they're getting carrier screening and told, oh my gosh, you have Pompe disease. They're totally healthy. So we have a lot of children who we're identifying to be at risk for late onset Pompe disease, meaning they've got the genetic risk, but they don't have any symptoms. So we have to follow them. And there is a very common classic variant that's cardioprotective that we can look at and say, oh, this baby's not going to be infantile onset. So what do? We already talked about the IOPD babies. We get them in, we start them really quickly on ERT, and we go from there. For LOPD, it's a little bit more difficult. We counsel them that it is a risk of late onset Pompe disease, that they don't necessarily have it. But because babies can't tell me, hey, I can't climb the stairs or I can't keep up with my friends in soccer, we do see them every 3 months for the first year with labs and a PT evaluation with a PT who is specific and very well versed in Pompe disease and the subtle findings of it. They do get a cardiac evaluation, but if they have one of those cardioprotective variants, it's not urgent. If we don't know what the variants are, if it's not a cardiac protective variant, it is a little bit more urgent and we see them more quickly. And then after the first year, evaluations get spaced out depending on what the genetics say and what the lab says. If the genetics say that they're a higher risk to have symptom onset very early, we follow them a little bit more closely. If their genetics say that they might make it to 70 and never have symptoms and their labs are all beautiful, we space it out a little bit more. In our hands, about 10% of babies, we're up to 60 referrals now from all 3 states over the last couple of years, and only 10% of those have shown any signs requiring therapy. And I say about 10, it's a little bit less than 10%. So we can be reassuring to parents whose children are at risk for late onset Pompe that they may make it to adulthood and never have any problems. They just need to see a doctor a little bit more often. In our hands, we also test older siblings who may have missed newborn screening, and that's a little bit less common now than it was when we started in 2019 because people having babies now are more likely to have had their kids while newborn screening was going on for Pompe disease already. But we are identifying children at risk for having LOPD by testing them if they have a baby sibling who is identified. So therapy for pediatric Pompe disease, there are 3 enzymes that are FDA approved. Only 2 of them are approved for children under 18. One of them is approved for infantile onset, that's aglucosidase, and avalglucosidase is only approved for late onset Pompe in children over 12 months. It is an IV medication, and it is 4 to 8 hours every 1 to 2 weeks of life. And so if you do the math, starting ERT on a baby identified to be at risk for something, when they're a baby, by the time they've hit kindergarten, they have spent a full 30 days in a hospital. So it's life-saving for infantile patients and improves function in later onset patients. But it is a big deal to do, and that's why we monitor and are careful about who we start ERT. All patients will have residual disease that's progressive, it's not perfect. Again, there are some of those infantile patients that we do immunomodulation on, and we would work very carefully with your office about vaccines and when they can have vaccines and when to hold off on vaccines if we have to do that. We also do supportive therapy with a high protein diet and respiratory muscle training. So Pompe disease is the love of my life. We're also going to talk about the other ones, but those conversations will be a little bit faster because they're a little bit more straightforward. So MPS, or mucopolysaccharidoses, on newborn screening, the ones that we currently screen for that are recommended by the Universal Screening Panel are MPS 1, which is Hurler disease and Shea disease, and MPS 2, which is Hunter syndrome. Again, we do an enzyme level first. If any enzyme is low, we do second tier testing. So we look for the stuff that builds up in MPS, which is called glycosaminoglycan. It's kind of the cellular snot, and it will leak from a cell if it's building up. And so the second tier is to look at glycosaminoglycan and say, is that high? Because it will be high in babies with severe disease. Any baby who has a high GAG level will be referred, and we will see them immediately. Well, we will see them in clinic. We don't do the genetic testing first anymore. This is newer. This has only been since 2024. So those of you who have been doing the newborn screening for LSDs for a while will probably have noticed that your reports of a positive MPS have gone down significantly. So this means that there's fewer false positives, but if you do get a screen, it is more likely to be a true positive, and we would want to see babies. Babies with MPS appear completely normal at birth, and they develop typically for a period, and then they plateau before regressing, but that takes years to happen. They may develop coarse features, which we'll show you some pictures of, developmental delay, macrocephaly. They have bony findings, so that's one of the things that we look for in babies who are referred to us. So spinal kyphosis, what we used to call gibbous deformity, they've got a bend in their back where it doesn't belong. Hernias and dermal melanocytosis, where they get slate gray macules, what we used to call Mongolian spots, in unexpected places like hands and feet, and not just over the sacral area. So those would be a little bit of warning signs, but again, unless they're severe, most of these babies will appear completely normal at birth and have really subtle findings. So that's why we see them. So again, in severe disease, MPS 1 and 2 are very similar. Symptoms start within the first year of life, but they may not be noticeable until at least a year old, and that's a little bit too late. They can develop macrocephaly, hydrocephalus, those coarse facial features. They get a chronic runny nose, recurrent otitis media. In MPS 1, they get corneal clouding, but that doesn't happen until they're at least school age, so not having clear corneas is not helpful. Eventually, they'll develop cardiac valve disease. They can get inguinal or umbilical hernias. Over time, they develop hepatosplenomegaly, but that's usually not present in the newborn period. They get that lumbar kyphosis, a bend in the back where they shouldn't have one. Dysostosis multiplex is that skeletal finding, and then the dermal melanocytosis. So this is what kids with MPS look like. These are the coarse features. You can see that the mouth is wide, the lips are fleshy, the brows are very strong, and there's some puffiness around the eyes. They've also got a depressed nasal bridge. Their nose is wider than family members and kind of almost like a button. And the nares, the nostrils, are a little bit thick. So everything is just thick and fleshy. And this is a baby who has one of the MPSs, and he's really cute, but he's also just a little bit coarse. So I wouldn't recognize this kid walking down the street and say, oh, that baby has an MPS. But if he came to me for a positive newborn screen, I would look really closely and say, yeah, we're developing some coarse features, compare him to his parents and siblings if we had any. So these are really subtle findings. MPS 1 can be divided into neuronopathic or neurodegenerative Hunter syndrome and less neuropathic or Shea syndrome. There is a high pseudodeficiency rate in persons of African descent, and in MPS 1, genetic testing may help predict severity. So every baby who has that positive second tier will come to us and get genetic testing, which might help predict where we're at. There is a risk of cardiomyopathy in severe forms that's not well reported in the literature, where we have about a 30% chance of all of our babies who truly have MPS 1 have come to us with really needing to treat their cardiomyopathy, but otherwise they can appear completely normal. What do we do when we get those babies? Again, it's changed since 2024. So we are seeing all babies referred to us for right now. When we see them, we get a diagnostic enzyme level. We get biomarkers. Again, those GAGs, those cellular snot bits that fall out of the cells and go into the blood and urine, we can measure them, and that can help us a little bit with predicting severity. And every baby does get a skeletal survey because that's one of the things that we can see early on that helps predict a more severe variant of MPS 1. Treatment it's a big deal. The only thing that will help preserve neurodevelopment is a stem cell transplant. Time sensitive, ideally before 6 months. If you can't get it before 6 months, then really by 12 months, most places won't do it after 15 to 18 months because by that point, the disease has progressed and the bone marrow transplant doesn't have enough left to fix. There is ERT for MPS 1 that will help soft tissue, but again, it won't help the neurologic symptoms. It won't help the neurodevelopmental problems. It can help the heart though, and it helps the liver and spleen and the tonsils, and it helps reduce the URIs and basically improves quality of life. and it can help make babies healthier in order to tolerate and survive a stem cell transplant. There are early clinical trials going on for gene therapies and for ERT that does cross into the blood-brain barrier, but those are not currently FDA approved. And we're also finding, similar to Pompe disease, we're finding more mild cases that don't need a bone marrow transplant, that fall into that non-neuronopathic, that are a little bit short, they're a little bit coarse, and we monitor those kids really closely because we're finding out that it's more prevalent than we thought. MPS II, if you look at the pictures, they're the same picture. It's MPS II is Hunter syndrome. They look very much like MPS I. It's X-linked, so it should only affect boys. It's very similar to MPS I without the corneal clouding. However, there's a couple of differences. The gene is very difficult to sequence, and so if you just do genetic testing, you're going to miss up to a fifth of true positive. And so that's why we really do need to do those specialized tests to make sure that we're not missing any boys. And then there are a number of pseudodeficiencies that exist. There's no particular ethnic overrepresentation. We're just finding a lot more of them as we're doing newborn screening and finding boys that their GAG levels are totally normal. Their uncle has the same change and doesn't have Hunter syndrome. They just have an enzyme that looks low in the dish. Treatment for MPS II is very similar. We do diagnostic enzyme biomarkers and a skeletal survey. There is an enzyme replacement therapy for Hunter, which does reduce the accumulation in soft tissues but doesn't fix the nervous system. In the US, we don't do bone marrow transplants for Hunter syndrome because it doesn't preserve the neurosystem. It doesn't work very well. There is a blood-brain barrier penetrant ERT that's approved in Japan, used in Japan. It's very promising in patients who don't already have significant delays, and it's going up to the FDA in early 2026. There are also clinical trials for a couple of different gene therapies for Hunter syndrome. And again, Hunter is similar to Hurler, where we can see those non-neuronopathic cases, and in those cases, we monitor them closely. Fabry disease is one of the lysosomal diseases that is not universally recommended, so it is screened for in Maryland, but not in the surrounding states. In Fabry disease, if the first enzyme is low, we do repeat it and only refer if we have too low enzyme levels. Fabry disease does not have symptom onset for years, so we have the time to do this. Fabry disease is never an emergency. These kids don't have to come to the ER. We don't need to see them within the next couple of days, but we try to because it's mean to the family to say, hey, you might have something, we'll see you in a month. But it is not an emergent thing. So Fabry disease is a storage disease affecting the nervous system, heart, and kidneys starting in the second decade of life. The classic form has renal failure, neuropathy, so numbness and tingling in the hands and feet, and cardiomyopathy. That can start in, very late teens, early 20s at the earliest. It's X-linked, so it affects mostly men, but females can absolutely be symptomatic. And they have very similar features. They just present a little bit later than their male relatives. And there are also attenuated forms, there are later onset forms, and there are cardiac only forms. So what do we do when we do get a Fabry disease referral? First, we do genetic testing by cheek swab to the home. So there is that chance of a false positive, so we do the genetic testing first on the affected baby who's referred to us. If there's positive genetic testing, we do screening labs and take a family history. This is X-linked, so we can find grandpas, uncles, grandmas who have kidney failure in their 60s, and we're told, oh, it's just because you're old and you have high blood pressure, but really it's treatable. So that's why we do take a family history. And then guidelines say to reevaluate these babies at 5 years old, because most of the time you wouldn't start ERT until they're at least 7. You wouldn't see symptoms. Fabry disease does not cause autism. It does not cause sleeping problems. So boys are allowed to have general pediatrics problems. We follow them a little bit more closely just so that they don't forget about it and so that they don't fall off the face of the planet. But the big reevaluation happens around age 5. Again, no treatment until late childhood, but we often find affected family members who we have to hook in with treatment. And treatment, there is enzyme replacement therapy and oral medication in some of the adult cases. I'm going to briefly touch on Krabbe disease. This was added to Maryland in July of this year. There is second tier testing, so any baby who has a low enzyme will get a second tier test looking at another biomarker and referred only if the second tier is high risk. There are some changes going on with our partners who do the second tier testing, so that our plans are in flux a little bit, but the big take home point for Krabbe disease is listen to what the newborn screen nurses advise you to do based on what we're finding at the time. Krabbe disease is horrible. It's a storage disease affecting primarily the nervous system. It has onset in fetal life with storage affecting the neurons. And these babies are extremely irritable. Babies with true infantile onset Krabbe disease typically die between age 2 and 3. There is the possibility of transplant before 28 days of life. So transplant, you need at least 10 days of conditioning. So you do have to have those babies in within 3 weeks to a transplant center, has been shown to increase the lifespan. But again, that's newer in Maryland. And so if you get a Krabbe screen, listen to what the nurses tell you, and the referral center will work with you on how to keep baby safe and how to evaluate baby. This is just really quick in case anyone out there is as much of a nerd as I am about how ERT works. So we're going to take us back to cell biology for just a minute. I promise we'll be quick. But if we go back all the way to cell biology, this is our cell. We have endoplasmic reticulum, genes make protein, and they eventually go to the lysosome. So the lysosome is the recycle bin of the cell. It takes all the garbage and breaks it down and recycles it so that one, it doesn't get in the way of the cell doing what it needs to do. Those pieces can be used. And really you want to be able to clean up the cell so that things can move around, so that if you're a brain cell, neurotransmitters can get where they need to go so that you're not getting in the way of muscle cells moving. Normally you have enzyme, either the green or the red, in there to help clean up your recycle bin. In ERT, we put the enzyme into your veins, it goes into your extracellular fluid. The cell has a receptor that says, hey, you belong in the lysosome, sucks it up and puts it in the lysosome. The way a stem cell transplant works is, since ERT can't cross the blood-brain barrier, but white blood cells can, it replaces the white blood cells. The white blood cells eventually get into the brain after about a year and a half, and they accidentally leak some lysosomal enzyme. And then the nerve cell picks it up. It also says, hey, you belong in a lysosome, and you get some cross correction. And you really only need about 5% of normal enzyme to not have any neurologic symptoms. So that's how stem cell transplant works, and that's how ERT works. All right. Talking really quickly for some of those of you who are on the border of other states, and how do we help those babies? So in Maryland, every baby gets 2 screens or more. Enzyme is always the first tier. Some of our disorders have second tier testing, but Fabry and Pompe don't. So all genetic testing is done through the referral center, and a positive on either screen can trigger a referral, and then the pediatrician or the PCP and genetics are both notified of the result by the state. If you are bordering Virginia, DC, or Delaware, most of those states are only a single screen. They all do enzyme as a first tier, and most of them do genetic testing as a second tier, and that's got its pros and cons that we don't have time to get into today. But usually they do require a second sample to trigger genetic testing to be done. So if baby is born in Virginia and sees PCP in Maryland, that makes it really difficult, because then they would need a second screen in Virginia to trigger that second tier testing. So if you are with Children's National, we will work with you to try and figure out how to get that second screen done, which state to do it through. The caveat there is, in DC, only the PCP is notified of critical results. So if you have a baby born in DC who lives in Maryland, you might be the only call for results. DC does not call genetics. So it's on the PCP to call us and say, hey, I have a positive screen, because the state or the jurisdiction of DC doesn't call genetics based on their protocols. So what happens with a positive screen? Maryland Department of Health calls the PCP first, asks how baby's doing, and asks which referral center you'd like baby to be referred to. Referral is then made to us. In general, we'll be calling your office and discussing with you And then we call the family after you've had the chance to call them and give them a heads up and give them a little bit of reassurance or say, hey, genetics is going to be calling you. If it's that Pompe screen, we'll be asking you, how's baby doing? Are they growing? Are they feeding well? For Pompe disease, we'll do an urgent in-person visit for any baby with concerning physical findings. Otherwise, we'll be doing genetic testing via a home cheek swab kit. MPS, because since 2024 we have that second tier testing, we're going to be seeing any positive babies for a diagnostic evaluation, but it's not urgent. And then Fabry disease is never urgent. We'll do that genetic testing by home cheek swab test, and then we'll work with the family to get them into genetics to see them. Um, Second tier testing, so Pompe disease without red flags or Fabry, how do we get those cheek swabs to them? We'll discuss it with family. There are some sponsored testing, so it's free of charge for the family. It's because the drug companies pay for it. So any babies with positive newborn screen or symptoms, the cheek swab goes to the family. The drug company doesn't get any information about the family. They just know, hey, Dr. Grant's ordering this test. It is ordered by and results come to genetics. So until we tell the state or until we tell you, the results all come back to us. It keeps baby out of the hospital, but it does have a longer turnaround time, needs counseling after the test. They still might have to come in for follow-up testing if it's a true positive, but that also means that we are not seeing the baby as an appointment. They might not have a medical record with us, so you might not get a formal note. You might get a phone call that says, hey, baby has nothing, we can close out the case. So some case examples, I'm just going to go through one for time, but baby had low GAA levels ×2. We got the genetic testing that we did at 5 weeks old. She had one severe variant and one of those cardiac protective. We saw her at 6 weeks. This was in the middle of COVID. So we had lab testing at Children's, but only one parent was allowed to come. Her biomarkers were a little bit elevated. Her CKs were in the 300s. Her AST, ALT were in the 100s. So not terrible, but higher than I would expect for a 6-week-old. Her EKG and echo were normal. Her repeat enzyme was low and her exam was great. If baby had had the low tone or cardiomyopathy or macroglossia, we would have seen her the day after the referral, but she was doing amazing. Turns out that baby had a 3-year-old sibling who we also tested, had low enzyme, same variants, normal CK, and this child was a tank. Her motor development was amazing, so we knew that it wasn't infantile. We thought that it probably wouldn't have onset early in childhood because we had a control. Over time, baby had 50th percentile on objective motor scales with PT evaluation until she was 30 months old. She was meeting motor milestones on time, but she was a little bit clumsy. Her CK went up to the 400s, and PT and I were noticing subtle signs of Pompe disease, both with her posture differences and some IT bands. Her objective motor scales decreased to the 10th percentile, but she was still officially not delayed. Pediatrician said she looked great, and her parents said, yeah, she's clumsy, but she's keeping up with her sister. So due to the labs and the biomarker and the falls in her objective gross motor skills, we did decide to start ERT on her. After 6 months, her parents say she's not clumsy anymore. She's keeping up with her sister. She's like turned into our little sports girl. Her gross motor scales went up to the 75th percentile. So now she's meeting her family, and her biomarkers completely normalized. So we know based on historical data that symptomatic LOPD has a 7 to 15 year diagnostic delay. You have to lose 30% of your muscles to present with weakness and to alter your activities of daily living. And so we found this baby years early, were able to start treatment, and we probably saved her 30% of her muscles and delayed being in a wheelchair, if at all, in her later life by treating her very early. So take home points, what do you do with a positive screen? Talk to genetics before referring patients because we can talk you through what to do. Is it really an emergency or not? Also, if you refer, you might not get seen in the appropriate time frame. And the LSDs, unless they've got signs of heart failure that we need to treat, they don't need to be evaluated in the emergency room. Red flags are really for that Pompe disease with hypotonia, weakness, poor feeding, heart failure in a baby with a positive Pompe screen. Fabry disease, never urgent. And just one of the things that I really want to drive home, the Maryland State Lab has done a great job with improving our specificity over time, especially with adding second-tier testing in the state. And so we used to have a bunch of false positives. Pediatricians would refer families, oh, it's a false positive, don't worry about it. That could sometimes delay care. Because we have second-tier testing now, our false positive rate is a lot better. We still have them, but it means that if we do have a MPS screen or one of those screens that has a second-tier test, we're going to want to see baby. And not every screen positive baby needs a formal genetics evaluation, but please don't become complacent because sometimes the intervention can be time sensitive. Who do you call for help? Generally, the state lab is going to call you first, and then a referral center will reach out. So the lab nurses will give you direction on possible urgency or non-urgency and who to call in case of help. If you choose to use children's, we have a newborn screen team where we have 2 genetic counselors for newborn screen who are first contact. If they're a lysosomal patient, then you'll see us, me, a PA on my team, and a genetic counselor on our lysosomal team. If it's after hours and it's not an emergency, there are the ACMG act sheets that are available for any newborn screen. The QR code there with the dinosaur is a link to that. So if you wanted to look at that, or you could just Google ACMG act sheets, and that tells you what you're looking for, what labs you might worry about, and gives you some information so that you can be educated a little bit if this is something that you've never heard of before you call the family. And then resources for families. We really like Baby's First Test. It is a website that lists all of the things Screen for on Newborn Screen that is really family oriented and gives them accurate information instead of, again, Google. Google is only going to show the absolute worst things, and then the families call us in tears thinking that their baby's going to die. We also at Children's, we have something called Bare Genes videos where a geneticist explains a concept. And so we have them for newborn screening. We have them for pseudodeficiency. We have a what to expect for a genetics visit. So those are available at that link. They're available at YouTube, and that QR code is takes you to our YouTube of pseudodeficiency if you'd like to look at it yourself or if you want to refer families to it. These are some references, so basically guidelines and consensus guidelines on what to do for all of those newborn screen conditions that we've talked about today. And I am happy to take any questions.
I have one, Dr. Green. This is Christine from the laboratory.
Yeah,
In your projections, do you foresee any other types of MPSs being added to the newborn screening panel, like Sanfilippo or some of the other
there are
disorders?
lots of family groups who would like to. The tenets of newborn screen is that it should be something that is treatable if diagnosed early. And so MPS 1 and 2 are more common. MPS 1 has a very time sensitive, again, within that 6 months. MPS 2 currently doesn't have an FDA approved treatment that is going to change the neurologic outcome, but there are multiple drugs and biologics in front of the FDA that have been approved in other countries that work the best if they are started very early. So some of these therapies might only be approved for kids under 2. So I'm not mad about finding kids who will still be in that setting where I might be able to help fix their brains. Right now, there are no treatments for Sanfilippo. There are not even clinical trials for a lot of forms of Sanfilippo. So attend some of the advocacy groups are trying very hard to get them added to the newborn screen. But as we're seeing from all of these, we are finding a lot of very mild cases that don't necessarily need treatment. And it depends on the state and if the RUSP comes back. But again, the tenets of newborn screening are that we should be treatable if caught early and not just to diagnose things. So I don't know the future. There are MPS 7 is treatable if it's caught early, but it's super, super rare. And I don't know of any of the advocacy groups that are going. There are a couple of other LSDs that are not irreversible that have advocacy groups trying to get it added to the screen, but it's up to the states. It's not up to me, so we'll see.
Follow-up question that's related to the mucopolysaccharidosis.
Mhm.
So we just started the non-reducing ends,
Mhm.
our state, and I was told that it had a really high specificity for disease, and we've had two to come back as false positive.
I
What's your
saw them.
take on
Yep.
that? Yeah.
Um, I think that it has significantly improved our false positive rate. We had with our first when we got our first newborn screen MPS diagnosis in the state, we had a 400 to 1 false positive rate just at Children's alone, and that didn't include the ones that were being sent to Hopkins, and they didn't have a true positive of a severe MPS. And so, as I'm sure because you've given me the numbers, we dropped to 2 referrals since January, or maybe 3 at Children's since July of 2024, compared to the 2 to 5 that we were getting weekly before that. And so it's helping with the carriers, it's helping with the pseudo deficiencies, and it's really helping, not having these parents who are Googling MPS 1 and thinking that their baby's going to die. So it's not perfect, but it's much better than enzyme alone. And I think both of those did have pseudo deficiencies. So I think we're getting a little pedantic here, but um, overall, the world of lysosomal experts are starting to realize that pseudo deficiency is a deficiency. It's just your residual enzyme is just enough to not have symptoms. And so it's probably going to be on the spectrum, but both of those babies did have pseudo deficiency variants.
Thank you for that. That makes my heart glad to know that we are making a bit of an impact.
Oh, it's
You know,
huge. It's absolutely huge. Like that, our department feels like we can breathe, and I'm not getting families calling me in tears, oh my God, my baby's going to die, which was a weekly occurrence.
okay. Well, I'll pass that message on to the team here. They work really hard to bring the assay up and to stay on top of getting these sent off to the reference laboratory. So I'm sure
Yep.
they'll be happy to hear the good news.
Yeah, it's
Thank
it's
you.
making a big difference for families.
Thank you.
It also means that we're seeing them quick instead of doing the genetic testing to the home, and it's reducing time to us because we're also only seeing those babies that are at higher risk to actually have a true positive. So it's preserving the healthcare system. All right, and I know Portia had a wrap up if we don't have any other questions.
Yes, I do. All right. So thank you, Dr. Grant. This was great. So thank you so much for giving us this talk on the lysosomal storage disorders. We would also like to extend our gratitude to all of you for joining us today. Even if you're watching this in future, we thank you. Your commitment in advancing newborn screening is very important, and it makes our progress in this field possible. As a reminder, today's session has been recorded and will be available for viewing at a later time. We did put the link for you to get registered to receive notifications for future webinars, as well as the link to our website that provides newsletters that we post out, as well as previous recordings of webinars. So we definitely encourage you to share it amongst your colleagues, and anybody else you feel like that will benefit from this information. So on behalf of our entire team, thank you once again for participation in today's webinar. We look forward to connecting with you at future events as we continue to work together towards improving the health and outcomes of newborns and families in the state of Maryland. So have a great afternoon, everyone.